So then maybe there's C4 missing or C2 missing or one of the main components. If we at the same time look for the alternative pathway, if there's also no lysis, then we know that here something is wrong with it. Combined part of the cascade between the two. And to distinguish a primary from a secondary deficiency, we have to look for activation products, either from C3 or the soluble membrane effect complex, which is also a good. We have to look for the autoantibodies, for regulators. This is just a couple very important. I will come back to this C1 inhibitor to look for protein. So the focus for clinicians to ask for complement analysis is twofold. On the one side, it's a so-called deficiency. So complement deficiencies are primary immunodeficiencies, and the ranking between around, let's say, 5 to 8% of all primary immune deficiencies are complement deficiencies. So what is a complement deficiency? What is the background? Of course, the leading symptom for all immune deficiencies are recurrent infections, either by viruses or by bacteria. Then we see that Neisseria, which induce a severe form of meningitis, that these are very often associated with deficiency of the late complement component and perturbing, which indicates that especially these microorganisms are killed by the lytic complex, by the membrane effect complex, whereas most other bacteria and viruses are killed by phagocytes. This is also interesting, that the interaction of T1 and 2 systemic lupus erythematosus, indicating that this is very important in terms of immunoregulation. So looking for complement deficiencies, we have global functional assays, quantification of individual complement components, functional assays of individual complement components, and analysis of activation programs. So this is how is this hemolytic assay done. We have serum, we have erythrocytes, we look for lysis, and then we have this, as I mentioned before, rabbit or sheep erythrocytes and close to lysis, and we read in a spectrophotometer hemoglobin at 412 or 541 nanometer, and then we can have a curve and to get information if it's sufficient, is it working or is it not. Recently, in a group of complement scientists, which was supported by the European Union, we developed a new system, ELISA-based system, to recognize also for screening of the deficiency of the classical pathway, the alternative pathway, or the lectin pathway, by binding on the surface of the ELISA plate either IgM or manane sugar, which is binding them to the first component MPL, or the LPS polysaccharide from the alternative pathway. We add human serum and some specific buffer which is required, and then we see that the complement component 1 binds to IgM, MPL binds to the manane, and C3 directly binds to LPS. And then the complex are built up, and then we come in with a monoclonal antibody against C9, which is bound to an enzyme, for example, the oxidase or alpha phosphatase, and then we give a substrate, and then we get an ELISA reaction. So if we have good color here and here, everything is okay. But if the color is missing here in the ELISA, we know something is wrong with the classical pathway. Actually, the same principle like the hemolytic assay, but if you can do it at the same time on the ELISA plate, and this has some advantages, some disadvantages. So this looks at finally here again in another picture that we have a signal coming from the substrate of the antibody which is linked to the enzyme, which is escape reaction. This is called now, it's now sold by a Danish company, Wieslab, and it's called the ELISA, complement ELISA system, and it's very good actually for screening complement deficiencies. It's not dependent on red blood cells, so in many laboratories laboratories, at least in Germany, the people do not have access to the erythrocyte from rabbit or from sheep, so it's easier there. It covers all three pathways. It's also sensitive for protein deficiency, which is a regulator, and it's very suitable for large-scale screening. In contrast to the hemolytic assay, it's only semi-quantitative. So, actually, in my laboratory, we are a reference laboratory for complement analysis in Germany. So, all the very interesting samples are sent to my laboratory. Also, some from Austria, from Switzerland, and even from Canada, from Toronto. And so, we see very interesting cases, and we figured out that the hemolytic assays are more specific a little bit and more sensitive and allow more quantitative analysis. So if we now find that there's no lysis in one of the systems and that we have that we think that the patient may be deficient, then we do protein analysis either by radioimmunodiffusion, nephrometry, neuroelectrophoresis, ELISA, most often by ELISA because it's more sensitive, or sometimes also. So I will give you just a few examples of cases we had in previous years. So this was a young boy, he had fever, very high, with so-called butterfly erythema. So all the doctors here know this must have something to do with lupus, systemic lupus erythematosus. He had a photosensitivity, proteinuria, and the histology of a biopsy of this kidney gave a diffuse proliferative with immune complex precipitation, and the immunohistology was that he had immunoglobulins, the immune complex is positive in immunohistochemistry, but no C4. So the question was, is there a complement deficiency? And then we did a very comprehensive analysis, and this is some years ago, and we published it in different papers. We looked with the first global assay, CH50 or FH50, there was no function. Then we looked individual, this is function and this is protein. Then we looked no C1 function, then we looked C1q, no function, but all the others were fine. And then we also looked at protein, and we saw, although there was no function, there was protein. So how could it have protein but no function? And then we did some experiments. We added to the serum of the patient purified C1q, and we could nicely restore the function, the total function of the classic pathway, the total function of C1. So this was a proof that there was really a deficiency, a functional deficiency of the C1q subtype. We also looked if this C1q is able to bind to its receptor on monocytes. This is a control which binds very nice. The patient C1q did not bind at all. And then we looked closer. We purified with different steps on a specific chromatography. We wanted to look closer to the molecule. And this is usually the control which comes up here, and this is the normal molecular size of C1q, but the patient came later in the illusion of chromatography. And then we looked even closer, and we found that the patient was not able to assemble the full C1q molecule, which is an hexamer, by 3 times this dimer, because this particular enzyme which leads to the assembly of C1q was missing. So this was the background. We had protein but no function, and then we also did some genetic studies, which we will have later discuss. So we were able to go very down to the molecular reason of this deficiency. So if we come to complement regulator deficiencies, we find C1 inhibitor deficiency in hereditary angioedema, and we go to this factor H with some forms of nephritis, but also with a certain form of blindness, which is, at least in Europe, the most often occurring reason for blindness is the age-related macular degeneration. Factor I deficiency with bacterial infection, but also with the renal disease, and also some membrane regulators. And this in particular CD55 and 9 is a disease which is called paroxysmal hemodynamic So I will give you as an example here. This is a study which was done by a colleague in Italy, Marco Ciccavi, and they had 435 patients which had these symptoms, and it's very dangerous. They start with some edema formation on the whole body, especially in the face. It's a differential diagnosis. Many doctors may think it's an allergy, but it's not an allergy. If you treat like an allergy, that's wrong. These people have a high risk to die because they develop the so-called larynx edema. It spreads immediately, and then they can't breathe and they die. It's very important to recognize and to have a differential diagnosis, because those patients they do not have an elevated level of IgE, they do not have an elevated level of eosinophils, and so it's very important to find what is the reason. And the reason is that C1 inhibitor, regulator, in complement is missing. But this regulator is not only working in the complement system, but it also acts on kallikrein-kinin system, on the clotting system, so it's a kind of global player. It's one of the most important inhibitors we have. And it acts on enzymatic reactions which leads to the generation of so-called kinins. And kinins are those peptides which lead to edema formation. So we have to diagnose it, and we have different types. Most of them, they have a very low C1 inhibitor efficiency, C1 inhibitor titer, and low C4. But there are 20% who have enough protein. If you only measure protein, you will not detect it, but the function is not there. It is a dysfunctional molecule, a mutation. And then there are also some patients who have no C1 inhibitor deficiency, but behave like an angioedema patient. And they may probably have mutation in factor 12. This is also very important, leading to kallikrein, because it's bladykinin. This is the action. This is a peptide, canine, which leads to the edema formation. And then we also have acquired forms, autoimmune forms, where we have an autoantibody against C1 inhibitor. And they have normal protein, but no function. So it's very important to have the protein diagnosis and the functional diagnosis. The next I will give you an example. Factor I, we had a family, which was a collaboration with the pediatric clinic in Sao Paulo. I have, since many years, I have a nice collaboration in Brazil, and they introduced the complement analysis with our help, and they found many deficiencies. And this was a 3-generation family with recurrent bacterial infection, indigenous parents, which increases risk to have the mutation passed over to the next generation. And there were 13 family members with partial factor I deficiency, and partial, and 3 of the siblings had a complete deficiency. And we found that there was no function in the alternative pathway, and there was low factor B. Here are the normal values below. They had a little bit lower factor H, but missing factor I. And what was also interesting, that the C3D, the split product, which is cleaved by factor I, because it was missing, there was no C3D. So we could easily recognize them, and so this is what's going on usually. There's C3D, and then with factor H together factor I cleaves the C3D to the subsequent. Again factor I with the C3D, and this was missing. And this is the serum of the patient of the 3 siblings, and this is normal, and this is C3D, so the final product which is available in normal serum. And then we added purified factor I, and then we see in the patient, it came back again, and here, like in the normal serum, after having substituted this regulator, the patient was able, the serum, to mount this peptide. The next example is the so-called hereditary syndrome, which is a severe renal disease of small children. And many of these children, they have a mutation in this regulator protein. What is hemolytic uremic syndrome? It's a syndrome, so you find different situations. And is there any nephrologist here in this audience? No? They have thrombocytopenia, so very low levels of thrombocytes, microidiopathic hemolytic anemia, so they have an anemia and they have an impaired renal function. They show in endothelial cell injury. There's also a form of hemolytic uremic syndrome which is associated with diarrhea. It's a diarrhea positive due to Zika toxin. And what I'm talking about is the atypical, no diarrhea, HUS. This has a complement regulatory deficiency. So these are some thrombocytes, and this is renal disease, and this is the microangiopathy. The complement factor 8, the protein, is built up of subunits. And some of the subunits binding to CCP as a regulator and here, but there are also some are binding to heparin, and especially this is binding to heparin. So it has cofactor activity for its reactivation and bind, and it leads to the regulation of the contact. Here factor I in the kidney is bound, and this is staining with collagen type 4, and if we merge these two pictures, green and red, we get yellow. So there we know that factor H is binding to collagen type 4. And we now, and this is already some years ago, now it's much more. We found already 100 different genetic mutations in the factor A molecule, more than 40 mutations in 2 different mutations, and more than 25 in one more factor application. So it's very much connected to a mutation in one of these regulatory factors. I will give you a case which we have followed and published in the England Journal of Medicine last year. 33-year-old woman had this relapsing HUS. She had this mutation of factor A gene specified here, and it started already with 25 years of age. Quite fast, she had to undergo dialysis. She had a relapse 5 weeks after the first renal transplantation at the age of 30. And then we had the second relapse 6 weeks after the second transplantation. So this is a very serious disease. If you have this mutation, you get a transplantation, and disease coming back, you lose a transplant. It's very difficult. Due to the fact that we have a very strong activation in the kidney, because the factor H, which is a regulator, cannot bind in the kidney. Due to the mutation, it cannot bind. And here was the first time that we gave, by the clinician, not me, gave eculizumab, which is a specific antibody to complement, 55. And tomorrow I will talk about the possibilities of therapeutic intervention to the complement system. And this is just one example. So this is some kidney stains, positive staining indicating that complement is activated in the kidney, in the glomerular capillaries, arterioles, in the K25. And what we see here are the platelets. This was before, and here is the time point of giving 0 eculizumab. We had a drop in platelets, so this is one major part of this analysis. And then what you see here is creatinine, which is function parameter from renal function, went up. So the normal value is below here. So it was very high, indicating that really the function was gone. And then there's very low haptoglobin, an indicator of anemia. And after giving eculizumab, the creatinine nicely went down, the function improved, the platelet number went up nicely, and the anemia was almost gone. It went up. So immediately we had a very nice treatment success. And we did some complement analysis following this patient, and what we see here is on the one side the function of complement, the total function, and what we see in red is one activation product. And during the time before the treatment eculizumab, the so-called anti-C5 antibody, we saw an up and down coming with the dialysis and plasma therapy. Every time when there was dialysis and plasma given, we had down, less activation product, and the function came back again. But then a couple of days later, it got wrong, adverse, and up and down. It wasn't up and down. But after giving eculizumab, we found the following. Of course, first the function goes down because the complement system is blocked. We do not see lysis. And after the drug was metabolized, the function came back again. But most important is we have an entire drop of this activation product, no complement activation, which stayed for a long time. And so with just one drug, one time treatment, we were able to treat successfully the patient. Meantime, we have a multi-center study going on with this drug to see if it really works in many, many patients of atypical HS, and the results will come out. So this is the deficiency situation, which is not the most important every day. The most important actually is the situation after the severe activation of complement, inflammatory disorder, which we know is happening after severe trauma, burn, and sepsis. The so-called systemic inflammatory reaction syndrome. Those who are working in intensive care unit know it, also the multiple organ failure as the severest consequence. Ischemic perfusion injury, important in transplantation, in cardiac surgery. Angioedema, capillary leak syndrome, hyperacute graft rejection is very much determined by complement, especially the hyperacute, which fortunately doesn't occur any longer because we have very good diagnosis, pre-diagnosis, but also the acute one, which rejection is dependent on complement. Vasculitis, all kinds of vasculitis is induced by complement. Nephritis, as I mentioned before. Autoimmune disease, not only lupus, but rheumatoid arthritis, multiple sclerosis, myasthenia gravis. There's lots of complement activation going on. Even Alzheimer's disease, we find in biopsies complement activation. And something which has to do with modern medicine, if we introduce foreign surfaces to the patient where the blood comes in contact, like dialysis membrane, cardiopulmonary bypass, and tubings, and all these machines, non-self, and so the complement system has to be activated, and this leads to a severe side effect. So many indications to do a proper complement analysis. Here we especially focus on the complement activation products. But we also look in biopsies. We can use monoclonal antibodies, which are bound to fluorescein or other groups, and then we can visualize the binding of this complement activation product or protein positively. The mean of this is our job. Mean is chemistry, cytochemistry, and this is the geometry. So we see, if for example in a disease, the autoimmune disease called Partial syndrome, we see it in lupus, we see it in post-coccal nephritis, and we see it in membranoproliferative glomerulonephritis, different form, very severe form, different staining patterns of if you look for C4 or C3 in this biopsy. So I will give you a few examples. For example, the lupus I mentioned because it's so important, and we have this case already, but we can also look on the platelet, on the thrombocytes of this patient, and these are the controls to this cytoplasmic analysis, where we can give to the cells a specific antibody which is bound to a fluorochrome, like PITS or something like this, and then it's incubated, and then it's given in a cytoplasmic machine, and then it separates the cells, goes through the channel, and then you have light coming in, and then you get an impulse out, and you can measure it. If it is here on the left side here, like in this six controls, we have no signal, this is just background, but in the 6 lupus patients, we see a second peak coming up here, 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 and here. And this indicates that we do have C4, C4D on the platelets, and this may be a marker also for lupus, systemic lupus nephritis. But primarily, of course, you have seen it before, we rely on the biopsy. This is just for comparison. This is the Khartoum syndrome. You see a very faint, very nice thing stepping along the glomerular basement membrane. But here it looks quite different. You would never recognize it different because these are the huge immune complexes which are binding a lot of antibody and fluid form, so they have a very bright light so that you cannot see the structure of the kidney. This is very typical for immune complexes in the kidney. Another example, for example, in bacterial meningitis, that we have an increased confidence regulator expression in brain epithelial cells, but also in tumor cells here, which I'm going to talk about tomorrow. This is a primary culture, taking a tumor from the patient and then bringing it to culture and cultivate it for a certain time. And then we look with fluorescence antibodies of different colors for the complement regulators C5, C9, and so on. And they are very much increased in tumor cells, the reason why they are so resistant. But maybe for the clinic more important, what happens in bacterial meningitis. Here's a control biopsy and here's the meningitis. And we have HLA2 and a couple of complement regulators here. And you see here in control there's not so much staining and everything is very strongly increased if we have a situation of infection in the brain. If you look for complement receptors, for example, in one of the diseases called deficiency, phagocyte deficiency, chronic granulomatous disease, we see a dysregulation of certain complement receptors. And if we compare them also in fluorescence analysis, we see them here very difficult to see. These are toll-like receptors, and these are the complement receptors, and you see that they are down-regulated in both patients who have this immune deficiency with phagocyte deficiency. And this is on the protein level, and this is on the level with PCR, reverse PCR messenger. So if I summarize, what I wanted to show to you is that there's a rapid development of highly specialized complement analysis in clinic and research, and this improves the diagnostics and is really important, a cornerstone for the advancement of the spelling mistake in research. But as everywhere in analysis, the standardization and quality control, especially in clinical analysis, is absolutely required. And this is the reason that we just established a committee of standardization of complement measurements in the world. This is the International Union of all societies of immunology in the world. And I'm chairing this and with some colleagues. And these are all the countries with their representatives currently including. And what we aim at is to have a standardization of complement everywhere in the world. And that will be checked by sending around samples, and everybody has to analyze it according to certain regulations, sending back the data, and then we compare them statistically, and they get a response if they have to improve the standards and the quality of their analysis, or if the laboratories are doing well. And this is actually something which is going on everywhere, not only in complement analysis. Standardization and quality control is extremely important in all kinds of measures we take in the clinic, but also in research. Also, research needs to rely on good standards and on a high quality control. So, thank you very much for your attention. Of course, I'm open to questions. Yes, please.
Thank you very much for the detailed talk. My question is about the car park, which is on complement activation related to other detect, there are certain drugs that may be used, especially on and we are in the group here that is part